Hello, everyone. Yay! Okay. I'm really excited to start session 3, which is cellular and molecular biology. And our very first speaker for this session is Dr. Kristyn Carter, who received her PhD in immunology at the University of Glasgow and is currently doing her postdoc within the molecular, cellular, and developmental biology department at Yale. So take it away.
Thank you. Hi, everyone. Thanks for the intro, and thank you to Kara for the program and inviting me to speak. Today I'll be talking about diabetic foot ulcers and translational biomarkers. Before we get into my actual work, I'll tell you a little bit about me. So way back in the day, I was a gymnast and a track runner, so I saw my fair share of injuries. And like most undergrads, I was pre-med. I thought orthopedic surgery was the field for me, but closer inspection, looking at surgeries in real time, bone repair is fine, no offense to any bone people in the audience, but I was more interested in how the surrounding soft tissue impacted the repair process. So my PhD focused on soft tissue immunology. I looked at fibrosis and recurring hand diseases, and I was really interested in how the immune system plays a crucial response in wound healing. So moving into my postdoctoral work, I was trying to think of different ways different diseases could render the immune system dysfunctional. I landed on diabetes due to my family connection. A lot of people in my family have type 2 diabetes, and it's especially common in the Black community and brown community and indigenous community in America. So we'll get started with diabetes. So diabetes is a chronic disease in which affects various organ systems differently, which is why treatment is so difficult. Diabetes occurs when your body is not able to transform glucose into energy. So when we eat, like we had a very nice lunch today, our body is turning that delicious food into energy for us to use throughout the day and to listen to talks about diabetes. It's diagnosed through tests, screening tests, where you look at your blood sugar levels to see where you are in the classification, whether you're normal, pre-diabetic, type 1, type 2. And symptoms include frequent urination, weight loss, and fatigue. Diabetes is very common in adults. Statistically speaking, not really statistically, but the most common countries that have the highest number of adults are China, India, and the US. And since we are currently in the US, let's take a closer look at diabetes in America. So pre-diabetes is a very interesting classification. Your blood sugar levels are higher than normal, but not high enough to be classified as type 1 or type 2. That's incredibly common. More than 1 in 3 people have been diagnosed as pre-diabetic. However, more than 8 in 10 are pre-diabetic and don't actually know. And those that have been diagnosed with diabetes, the numbers goes down from 96 million to 37 million actually diagnosed, which numbers is about 1 in 10. But 1 in 5 people don't even know they have it. So how is it that these people can have pre-diabetes or be diabetic and not know? I'm sure we're all familiar with the challenges of the American healthcare system. Access to screening and doctor's appointments and actually transporting yourself to the doctor are one of several barriers that exist, which is why the numbers of people who are in these classifications and don't know it are so high. So thinking about the classification of diabetes, we'll just talk briefly about type 1 and type 2. As I mentioned, you can be pre-diabetic, and you can also have gestational diabetes, which occurs in those people who are pregnant. Type 1 diabetes occurs when your body cannot produce enough insulin. Insulin is a crucial hormone that helps your body take the sugar from your bloodstream, deliver it to the cells to use for energy. It's typically diagnosed in children and teens. As I mentioned previously, the symptoms, especially in children, the most significant one is weight loss. It's pretty scary seeing a child with type 1 all of a sudden go from 90 pounds to 70 in a matter of months. And treatment focuses on insulin injections, consistent blood sugar monitoring, and meal planning, which sounds really crappy as a kid. I know I loved candy and ice cream, and if I couldn't do that, and that would really devastate me. And type 2 diabetes, classified as high sugar in the blood. So again, commonly diagnosed in adults. Symptoms include blurred vision, slow healing sores, and frequent infections. I did mention that diabetes affects different organ systems. One of the most studied ones is the vascular dysfunction that occurs, which leads to blurred vision and sometimes vision loss in people. And again, treatment focuses on disease management through oral medication or injections and dietary restrictions. So one key element I want to point out here about the treatment of diabetes, it focuses on management. we don't want to manage our lives, right? We want to enjoy our lives, which is why we need to study diabetes, why we need to develop better treatments, more successful treatments. So thinking about the healthcare system and the costs related to having diabetes renders about $327 billion in lost work and wages and total medical costs. Medication is incredibly expensive, and again, doctor's visits, the copay is high. And sometimes insurance doesn't cover the necessary tests and medications that you'll need. And thinking about the side effects, so again, blindness as a result of vascular dysfunction in the eye can lead also kidney failure, heart disease, and then in my family, stroke is something that's happened. Both my grandfathers passed away, complications of diabetes, they both had strokes. But not studying something too close to home, I am focusing on the loss of toes, feet, and legs. So those of us that use our legs and feet for mobility, there are common sources of injury, right? When you're diabetic and you have a wound, it doesn't heal properly. That wound can become infected, further damage, which can then lead to amputation. And that is where my research comes in. Diabetic wounds become unhealed ulcers, shown here. About 2 million people, 2 million Americans, of those numbers I showed previously that have been diagnosed will develop these diabetic foot ulcers. You'll notice here the surrounding tissue is red, the wound is open, and there is no healing. These ulcers are chronically inflamed and non-healing. They're susceptible to infections, molecular dysfunction as a result of diabetes, and repeat damage. Again, those of us that use our feet, if your wounds are on the bottom of your feet, every time you take a step, imagine that pain. That is further damage to your tissue. And treatment for these ulcers includes several painful clinic visits and expensive medications. I've seen this firsthand. Part of my postdoctoral work involves clinic visits. So I'm actually watching people that have lost their limbs undergo wound debridement where affected tissue is removed. It's not pretty. So I focus on why these wounds are chronically inflamed and how we can promote healing. The stages of healing and repair are divided into inflammation, which is the initial response that mediates tissue repair. I just showed a little schematic here with immune cells flooding in from the bloodstream, initiating the inflammatory response, followed by proliferation, where your damaged blood vessels begin to grow, creating a supply of cells and nutrients to that wounded repair tissue. And you also have that nicely formed granulation tissue, which is a fancy word for newly formed tissue. And inflammation calms down, finally leading to the remodeling stage where the wound has reformed, the tissue architecture has reformed, the wound has closed. With diabetic foot ulcers, proliferation remodeling doesn't happen. Think of like potholes in concrete. That pothole never reforms. And if you live in Connecticut, you know how much damage it can do to your car. So taking a closer look at what this actually means when I say these wounds are stuck in the inflammatory stage, there's persistent inflammation in the wound tissue. So again, that redness, that open sore. Delayed remodeling or no remodeling prevents rebuilding of the tissue architecture. And open wounds, again, remain susceptible to infection or damage, which can lead to amputation in most serious cases. So my work focuses on using diabetic foot ulcers and non-diabetic foot ulcers, trying to understand which biomarkers we can use to develop better treatments. I use single-cell sequencing, histology, and mRNA expression. I'll just show a few bits of data here. Single-cell sequencing of diabetic and non-diabetic foot wound tissue will show you differences in the tissue architecture. Most notably, we see decreased keratinocytes, which are important for skin rebuilding. But interestingly, we see more fibroblasts, yet remodeling is delayed, so what are they doing? And also, about the same number of macrophages, yet diabetic tissue is supposed to be more inflamed. You'd expect macrophage numbers to be much higher. So thinking about the other techniques I'm using to interrogate this tissue, I turn to histology. I've shown here non-diabetic foot wound tissue and diabetic foot ulcer tissue. You'll notice that CD45, really beautiful green stain, CD68 positive, macrophages in red, whereas in the foot ulcer tissue, we see hardly any CD45, but we do see spots of macrophages. So this proposes a lot of questions about what's happening with the immune system. And those of us that do human work, I'm sure, are very fond of IRBs and patient recruitments and trying to get that N number high, which is always a challenge. So in thinking about how I can interrogate this immune response, I have to think about other models I can use. My work uses mice, specifically diabetic mice, trying to understand how this dysregulated immune response is promoting this pro-inflammatory chronic wound. And more specifically, how can I modulate this behavior? Using a mouse, I didn't show here, I wasn't sure how people would respond to seeing mouse wounds, but on the backs of these mice, I use a 4mm punch biopsy tool to create even wounds, 6 wounds on the backs of mice, and I'm able to collect wounds on days corresponding to the stages of repair I mentioned previously and interrogate them further. But as I mentioned in the clinic, these visits are very intense, and some people end up losing their limbs. They do everything the doctor tells them to. They change their diet, they exercise, they haven't had ice cream in 20 years, but it's not working. So if diabetes is so destructive, where there are people on the outliers that are not responding well to treatment, these wounds aren't healing, they're suffering even more, it's forcing me to think outside the box, or I guess in this case, outside the body. So what tools can I use to challenge the destructive nature of diabetes? So I also incorporate biomaterials as a means for intervention to improve wound healing. Biomaterials are engineered substances that interact with our living systems, and specifically, I use hydrogels. These are water-based materials, think of like hair gel or like Eco-Styler, and they retain their structure over time, and they act as the concrete to fill in that pothole of the wound. Hydrogels, in general, can deliver anti-inflammatory properties, specifically with the diabetic wound, and can promote healing and tissue remodeling. So early stage intervention in my mice has shown that repeat administration has improved wound healing, and we've created this barrier between the outside world and the wound environment that allows that, or prevents repeat damage. So thinking about how this will help people, and if you're interested, stay tuned, humble plug there. What I envision is these wounds will be able to be sealed, not in a painful way that will prevent people from having to come back to the clinic to undergo that debridement, but creating a space, creating a material that will harden on the bottom of their feet, preventing that tissue from enduring more damage. The tissue responds really well to the hydrogel, and so there is no issue of it popping off. And eventually, we would have a healed wound response. So my greater vision for this work is much like what happened with the COVID tests, how we were able to get them delivered to our home. Being in the wound clinic, I'm coming face-to-face people that have very serious challenges and barriers with the medical system. Getting to the clinic, getting appointments, access to healthcare, access to a CVS that carries their drugs. My hope is that I'm able to not only create a gel that works in mice and creates a really cool paper, but I can create an at-home kit that people can administer themselves in the safety and comfort of their own home. All of this work is the foundation of what I hope to be, or no, not hope, what will be the Carter Lab. So taking clinical research, interrogating the immunology of this tissue, and considering diseases that are destructive, like diabetes and cancer, using biomaterials to then alter that immune response, promoting healthy, healed responses, and then giving it back to the community. So using mouse models, and then hopefully my kit, with the overarching aim of using tissue engineering approaches to promote regeneration of disease and damaged tissues, not only to promote repair, but creating accessible treatment options. And hopefully one day you'll see me on Shark Tank peddling my hydrogel kit. And so with that, I'd like to thank my PhD group, tendon biology group led by Neil Miller, my postdoctoral group led by Valerie Horsley, countless friends, family, and supporters, and especially a few groups I want to highlight is the Yale Black Postdoc Association, the National Black Postdoc Association. Postdoc life is hard, isolating. Without them, I would not be here. And so with that, I will take any questions.
Great talk. Am I going? Yeah. All right. So I have one naive question. How does that hydrogel stick to the skin? And then my second question is, have you played with the stiffness of the materials? Because, for example, there is some evidence that change in stiffness in these biomaterials can promote or inhibit regeneration in different contexts. So.
So I answer the second question first. So there's actually a postdoc in the Horsey lab. She works on biomechanics, and she's looking at fibroblast response to stiff and soft materials. So that is something that's definitely coming. With the hydrogel, it's thermoresponsive. So at 4 degrees, it's like really nice and liquid, and once it touches a warm surface, it adheres. And then over time, it degrades. I always say macrophages are like the toddlers of the immune system. If they're not happy, nobody is. You'll see in my work the macrophages respond really well to the hydrogel. They degrade it very nicely. And after about 20 days, it has fully been incorporated into the mouse wounds. But stay tuned.
Hi, so Jay, for those that can't see me, at Fox Chase Cancer Center. So you mentioned fibroblasts, and you mentioned that there are higher fibroblasts in the diabetic ulcers, and you said, what are they doing there? And I don't know if that was bait, but you baited me. So what do you think they're doing if anyone has started to look into that? And then, if not, maybe we should collaborate when the future Gardner and Carter labs exist.
Well, one, yes to collaboration. Always good to make friends. As far as this like fibroblast population, it's pretty strange. I honestly think this sample is a bit of an anomaly. Looking at my other histology, looking at alpha SMA staining, you don't see this increase in alpha SMA. In my diabetic foot ulcers. So this may have just been like the sample that we chose. They had higher fibroblasts, and maybe they are being produced like more to try and start the remodeling process. But I guess, okay, so maybe if we have chronic inflammation in the wound, maybe those fibroblasts are persistently being activated by macrophages, for example. You have a, excess inflammatory response, excess fibroblasts, differentiation to myofibroblasts, and that could be what we're seeing. But they could be dysfunctional, which is why we don't see that increase in matrix protein expression. We don't see that filling in of the cavity. But collaboration on the table.
Yeah, definitely the collaboration.
I'm in, baby. I'm in.
Yeah, because so just for a note, though, at least for looking at alpha smooth muscle actin as a marker, we've seen sometimes that like fibroblasts can almost reach an exhaustive state where they kind of lose alpha SMOS signaling, but they're still active. So that may not be the best marker. Right now, we've kind of been using potoplanin as a really good fibroblast marker that seems to be panning out. Okay. That maybe that could be something that you look into to see if there's enough fibroblasts actually in your samples.
Yeah, so I've been using, going off on a tangent now. We could talk later too. I've been using potoplanin as a stromal cell marker, potoplanin and CD90. I was thinking of using FAP, fibroblast activating protein, because a lot of head shakes. Okay, no.
I see both me and Rebecca like, nah.
We'll talk later. Thank you for your question. Glad I asked for the order of the antibody.
Yeah. Okay.
Yes.
I won't ask about fibroblast. I had two kind of so do the macro? I don't know how you would be able to know this, but are there more? Is the lack of immune cells in the wound, like if you could somehow get an unwounded diabetic foot, would you have fewer immune cells there than an unwounded non-diabetic foot? Like, is the starting state just different, or is it also the wound response is different, or like both? I don't know if you can do that experiment. It seems, now that I say it out loud, a little challenging.
Actually, we did flow cytometry, looking at the early stages of wound healing, and in the mice, obviously, because the foot tissue
the
is
mouse
a bit...
is a nice model for that.
Right, it's good. So the initial stages of wound healing, the macrophage influx is the same, but it just persists. So I would look at like day 0 to day 3 in control and diabetic. The numbers are the same, quantification of neutrophils and macrophages, which is interesting because you think, and conceptualizing this, I thought, okay, vascular dysfunction, crappy blood vessels, whatever, maybe they aren't able to get to the wound site, but they're actually there.
They're just not doing the right thing.
Yeah, so I'm like, what are they doing? And how can I reprogram them? So, yes.
Yeah, so that gets to my other question of have you, now I'm more of a biomaterial nerd. Can you add things to your hydrogel and functionalize them to potentially get your cells to behave? All right. Okay.
Next. No, but excellent question. Yeah. Stay tuned. Something I'm working on.
Me? Yeah. Okay.
Hi.
Hi.
Keelan, Sylvester Comprehensive Cancer Center. Okay, 2 questions. So the first one is, I know you said you do patient clinic visits. I have to ask I'm not familiar at all. At the population level, are there differences in the number, are there differences at the population level in the amount of ulcers that form in diabetic patients, and the severity of those ulcers? And then the second separate but related question is, when you think about the fact that inflammation is a mediator of stress and metabolic disease, to what extent can you account for other types of psychosocial stress that might affect an immune response? And have you thought about how that might affect the way that your intervention actually works across different types of folks?
Yeah, amazing loaded questions. I love that. The first one you asked about location and quantity of wounds. So some of the diabetic patients that come into the clinic are wheelchair bound, and some of them have most of their wounds on the backs of their thighs and their legs. So it's not, it usually starts off as a foot, on a toe, but then, the infection is too bad and they can't walk, but then they end up developing more. So yes, that does happen. And then you do have some that diabetics that come into the clinic with starting off as a toe wound, they end up cutting off the toes. Cutting off the toes. It's okay. And then they end up getting more wounds around their ankles. So the numbers do differ between those who are non-diabetic and diabetic, but also mobility challenges as well are playing a role. As far as other stressors, thinking about the barriers of the healthcare system, there was a woman who came in, she was really stressed. She couldn't get an Uber and she was late and missed her appointment and they wouldn't reschedule her. And it's hard being in the clinic, but it's, part of it. And so thinking about the stress that she's undergoing and she's limping, trying to rush in the parking lot and that's hurting her wound. That's not good for her. And so if there was a way to say, we will call a cab for you, you come comfortably, we'll give you a walker, we'll put you in a chair, something even just getting her to the clinic, to the actual clinic room could reduce any kind of further damage she could do just in that situation. So thinking about lifestyle as well could definitely, absolutely play a role in the biology that we're seeing. So thank you.
Yeah. Thank you, Dr. Carter.
Thanks.